Welcome. Today we're taking a deep dive into a virus that, believe it or not, most of us will carry for our entire lives. Human cytomegalovirus, or CMV. You can think of it as a silent passenger in the vast majority of people, but for some, it can be absolutely devastating. And we're going to unpack exactly why.
So here's how we're going to break this all down. We'll start with the basics, what the virus is and the disease it causes. Then we'll get into how we actually identify it, how we treat it in adults and in kids, and what the big picture public health strategies look like. And we'll wrap up by looking at what's really at stake, the serious complications we're trying so hard to prevent.
All right, first things first, let's get to know this pathogen and the wide range of diseases it's responsible for. Okay, so at its core, CMV is part of the herpesvirus family. And just like its cousins that cause things like chickenpox or cold sores, it has one absolutely critical feature. Once you get infected, it sets up shop for life, entering a dormant or latent state in your cells. This latency is the key to everything, because it means the virus can wake up and reactivate later. It never really goes away. After you first get infected, the virus usually incubates for about 4 to 12 weeks before you'd see any symptoms, if you see them at all. But in really high-risk situations like getting a blood transfusion or an organ transplant that has the virus, that whole timeline gets sped up a lot. Disease can pop up in as little as 3 to 8 weeks. So how does this thing get around? Well, the virus is shed in pretty much all bodily fluids. We're talking saliva, urine, blood, breast milk, you name it. And that's why close personal contact is the main way it spreads, especially in places like households and daycare centers. Now, this is really cool. Under a microscope, CMV leaves behind a very specific calling card. When pathologists look at infected tissue, they see this classic owl's eye look. These are enlarged cells with a giant inclusion right inside the nucleus. This is what we call pathognomonic. If you see this, you have just diagnosed a CMV infection, plain and simple. It's the virus's own histological fingerprint. And this slide right here really gets to the heart of the CMV paradox. In a healthy person with a strong immune system, that system basically keeps the virus locked down. The result? Few, if any, symptoms. But you take someone who is immunocompromised, say a transplant patient on anti-rejection meds, and that security system fails. The latent virus reactivates, it spreads, and it can cause severe, life-threatening damage to organs. So, given those two completely different outcomes, how do doctors figure out who has a harmless latent infection versus who has a dangerous active one? Well, that brings us to diagnostics. The workup usually starts with serology, looking for antibodies in the blood. But to tell the difference between a new infection and an old one, and more importantly, to guide treatment in those high-risk patients, the absolute gold standard is PCR. See, unlike an antibody test, a quantitative PCR doesn't just tell you you've been exposed, it directly measures the amount of viral DNA in the blood, the viral load. It gives us a real-time snapshot of what the virus is doing. All right, so when treatment is needed, what's in the toolbox? The main weapons are drugs called DNA polymerase inhibitors. They work by stopping the virus from making copies of its own genetic material. Ganciclovir is the go-to, the first choice because of its effectiveness. Foscarnet and cidofovir are powerful backups, usually kept in reserve for when the virus is resistant to ganciclovir or if there are toxicity problems. So how are these drugs actually used? Let's zoom in on the very specific, highly structured protocols for organ transplant patients, where CMV is one of the biggest infectious threats they face. In the world of transplantation, prevention is everything. This table shows the game plan for kidney transplants, and it all boils down to the CMV status of the recipient and the donor. Just look at the highest risk combo, a negative recipient getting an organ from a positive donor. That person has zero prior immunity, so they get the longest course of preventative antivirals, a full 6 months to shield that new kidney. Now, for liver transplants, the strategy can be a bit different. Instead of giving everyone preventative drugs, a lot of centers use what's called a preemptive strategy for recipients who are already CMV positive. What that means is no drugs up front. Instead, they are watched like a hawk with regular PCR tests. If the virus starts to wake up, then the treatment starts. It's a smart way to avoid giving powerful drugs to patients who might not even need them. And this is the trigger for that preemptive strategy. It's not based on how the patient feels. It's all about the data. When those routine PCR tests show the viral load has spiked past a certain point, often around 10,000 copies per milliliter, that's the alarm bell. It tells us the virus is breaking free from immune control, and it's time to step in with antivirals before the patient actually gets sick.
The virus is a whole different ballgame when we're talking about newborns. So let's shift our focus to pediatric CMV and the absolutely crucial difference between congenital and postnatal infections.
And this distinction is clinically vital. For a newborn who has symptomatic congenital CMV, meaning they were infected in the womb and are sick at birth, a 6-month course of antivirals is the standard of care. We know it improves their long-term hearing and brain development. But for a healthy, full-term baby who picks up the infection after birth, which is usually harmless, we generally don't use antiviral treatment. Knowing how to treat the bad cases is one thing, but with a virus this common, how do you even begin to manage it across a whole population? Well, that question takes us into public health and prevention. With no vaccine out there yet, prevention really comes down to simple hygiene. The main reservoir for CMV out in the community is young children. They can shed the virus in their saliva and urine for years without being sick at all. So for people at high risk, like pregnant women, simple things like obsessive hand washing and not sharing forks or cups with toddlers become a critical line of defense.
And this really gets at the core challenge here. As one source perfectly put it, trying to control a virus shed by healthy, happy toddlers, well, it's like trying to get a toddler to nap. It sounds simple on paper, but in the real world, it's chaotic and universally disruptive.
This risk isn't just a casual concern. It's taken so seriously that for people in high-exposure jobs like healthcare and childcare, CMV is a recognized occupational hazard. In fact, in some places, like the Netherlands, if a doctor diagnoses a CMV infection that was acquired at work, they are legally required to report it. It's treated with the same seriousness as any other occupational disease.
And finally, let's circle all the way back to why any of this matters. All of these strategies, from diagnostics to treatment to prevention, they're all designed to stop the devastating complications of this virus.
The fallout from a congenital infection can be profound and permanent. It can range from things like low birth weight and jaundice to severe neurological damage, like microcephaly, seizures, and one of the most common outcomes, permanent hearing loss. And the timing here is critical. If the mother gets infected earlier in her pregnancy, the damage to the developing fetus tends to be much more severe. Okay, to pull all this together, let's think about a question. What is the main reservoir for this virus? If you're thinking humans, you are spot on. CMV is an obligate human pathogen. It can't live in animals, it doesn't survive long on surfaces. Its entire existence depends on us. We are its only known host. Which leaves us with one final big question to chew on. We've seen just how common this virus is, and we've seen the terrible potential it has for the most vulnerable among us. So given everything we know about its biology and its impact, what's really standing in the way? What are the final scientific and logistical barriers to creating an effective, universal CMV vaccine?